All right. So hello, everyone. Welcome to a fireside chat with Doctors Boris Heifets and Laura Hack. Today, we are going to have a discussion about science and medicine at the border of anesthesia and psychiatry, a discussion of the future of precision brain state engineering. So now for a brief introduction of Dr. Boris Heifets. He has had a lifelong interest in neuroscience, non-ordinary states of consciousness, and neuroplasticity. He is an assistant professor in the Department of Anesthesiology, Perioperative, and Pain Medicine, and by courtesy in the Department of Psychiatry and Behavioral Sciences at the Stanford School of Medicine, where he maintains a clinical anesthesiology practice, directs clinical trials, and runs a basic neuroscience lab. He received his undergraduate degree in neuroscience from Yale University, MD PhD degree from Albert Einstein's College of Medicine, and completed anesthesiology residency and a neuroanesthesiology fellowship at Stanford Hospital. Now for a brief introduction of Dr. Laura Hack, who is an instructor in the Department of Psychiatry and Behavioral Sciences, deputy director and esketamine lead in the Precision Neuromodulation Clinic at the Palo Alto VA, and director of novel and precision therapeutics within the Center for Precision Mental Health and Wellness. As a practicing psychiatrist, Dr. Hack has a passion for better understanding subtypes of depressive disorders using data from multiple modalities and targeting these subtypes with novel therapies. Facilitated by the center, Dr. Hack has had the opportunity to collaborate with Dr. Heifets over the past 3.5 years on projects spanning neural mechanisms of ketamine and MDMA in healthy subjects to the effects of a single dose of interoperative ketamine on depressed patients, to case reports of anesthesia-induced dreams correlating with the resolution of PTSD symptoms. So Boris, perhaps to get started, you can tell us a little bit about some of the projects you've been involved with.
Sure. Thanks, Jacob, and thanks, Laura, for coming on. This is, I believe, the inaugural Precision Mental Health Center fireside chat. I'm feeling very cozy right now, and it is December, so this all seems very appropriate. It's again, Laura, I'm particularly happy to be on with you. We've our collaborations have only grown over the last couple of years. We're both junior faculty with a couple of years difference, but I think that there's, since the time that you've come on, and certainly over the time I've been at Stanford, there's been a tremendous growth in the amount of work that's being done on drugs that really you couldn't base a career around even 5 years ago. Things like ketamine, MDMA, psilocybin. Ketamine actually, I think, has been already we've jumped the shark on ketamine, but there's a tremendous amount of work now that is ongoing at Stanford that's getting into some of the most interesting aspects of how ketamine works. So I don't know, Laura, what's your how have you found the last few years at Stanford?
Yeah, I mean, it's been so exciting, and it's been really great working with you. You are doing just such innovative work in this area, and these rapidly acting psychedelics have such a amazing potential to help people, and there's just this huge unmet need. So I think it's the work that we're doing together is just so important.
Well, I have a few slides to that effect, and as you can I think as you will continue to see, and certainly our audience I think hopefully will appreciate, this is not possible. This is not a one person endeavor by any means. I'm not a psychiatrist. I like to moonlight, I guess. But anyway, it takes expertise from anesthesia, sedation, rapid alterations in physiology, pharmacology, and right alongside with all of the diagnostic therapeutic tools that you developed in psychiatry that I am learning about, but don't know much about, enough about yet. And that's really what we're here to find out. So I'll show you a couple of slides just to give you a broad overview of the work that's been going on in my group. And again, you'll see a lot of this plays into things that you're doing in the Precision Mental Health Center, and in some of these projects are well. And yeah, so this again, this is a presentation that I've given before, and it's going to be greatly abridged. But I want to give you a flavor for how some of these new drug therapies, these new ideas about therapy, really play out mechanistically, and where the future is going to take us. So the first thing I think the groundwork is really laid by patient encounters, and that I think was where a lot of this starts. And this is an actual email I got from a patient, unsolicited, not even at Stanford, actually. She read about some of the work we were doing, and she wanted to relate this experience. She chronic pain patient, multiple orthopedic surgeries in her ankle. And she's telling me about just the last surgery she had. It was the morning after a January outpatient surgery. Something happened to this day I find difficult to explain. She felt great. I initially attributed my feelings of increased energy to finally having relief from getting the hardware out. And that, of course, is the hardware in her ankle. And while she's still awakening with severe night pain, the emotional anguish of those long nights was gone. When this almost euphoric feeling continued for more than a week, she began trying to assess what was happening and why. Now, I wouldn't be sharing this unless we didn't have at least some inkling. The only difference between this surgery and the 5 preceding ones was she got ketamine. How that relates to her postoperative recovery, I think that's the most interesting question that we had to answer. And the ketamine is one of a number of therapeutics that have gotten a lot of attention lately. Ketamine's actually been around in anesthesia since the 1970s. I'm appalled to say that we did not notice in anesthesia the first antidepressant use of the drug, but nonetheless, there are a number of developments in the 90s in neuroscience and psychiatry led them to test ketamine for depression. And this is one of the early studies, a randomized placebo-controlled trial on ketamine. And you can see here the depression scores on the y-axis, and you can see the resolution of symptoms very quickly in the group that received ketamine and not in the placebo group. This is, these studies have been going on for the last 15 years now, larger and larger trials. And there are other therapies that seem to have at least some things in common. This is psilocybin, again, effects on depression. This is specifically, this trial is from NYU study, but there is a number of groups have reported similar effects, and now a large phase 2b trial from Compass has shown something very similar, that on standardized scales of depression, a single dose of psilocybin can induce these monster effects. Now, there is a lot of question, about how will this kind of effect, will we keep seeing it? How much is due to the hype of psychedelics? How do we design appropriately controlled trials? These are all incredibly important questions that I'm not even going to touch on. But again, the phenomenon is there. This is a bigger signal, I think, than anyone's seen in neuropsychiatric disorders for decades. So that's really attention grabbing. And of course, MDMA is another example of this, where 1 or 2 doses given in the context of therapy for post-traumatic stress disorder seems to be remarkably effective and durable. This is just showing a 2-month outcomes in a essentially open label trial, which all of these trials essentially are, because it's very difficult to blind patients to the effects of MDMA. But again, the thing that really binds these therapeutics together is the rapidity of onset. In some cases, 4 hours, but about a day, patients are already feeling something very different. The effects outlast blood levels of the drug. That's really not something that we're used to. That's not the SSRI model. So again, and well, I think it's interesting that these molecules that have totally dissimilar pharmacology share these properties. And what's more, the future of psychiatry, which is, I think, encapsulated in this slide. This is, I think, one of the most exciting directions, at least alongside, things like TMS and other novel therapeutics. It increasingly looks like monitored care, closely monitored care with therapy and direct supervision during intense pharmacological and physiological manipulations. Now, if I were giving this to an audience at the American Society of Anesthesia, everybody would immediately recognize their own job description of that. That's really, very close to what we do in the ORs, where we are really controlling extremes of physiology through pharmacology in order to get patients through a very powerful experience, which is, I guess, one way to refer to surgery. There are other ways you can talk about it. So anyway, so that's really that's the rationale for where I think these two fields intersect. And I'm going to try and condense a lot of work in a few slides, but really why are we so interested in drug mechanism? And it comes down to the fact that while there are amazing signals out there for efficacy, there's actually quite a bit of unknown aspects to these therapies and risk, frankly. MDMA, has a lot of potential, but there's an enormous there's an enormous opportunity for misuse and abuse. For MDMA, for ketamine, we don't know who psilocybin is really most appropriate for. And, this is basically where our lab's work comes in, is we try and really take this back and forth from animal modeling to testing mechanism in humans and everything in between. And I keep promising I'm going to tell you about the work we're actually doing. So now we're going to get a little bit closer. So, you folks watching may or may not be so familiar with MDMA, but one of the most poignant quotes that I recall reading. This is the father of the MDMA Renaissance. Sasha Shulgin wrote this book called Phenethylamines I've Known and Loved with his wife Anne. And one of his recollections was about taking MDMA was that it opened up a person to other people and inner thoughts. And he decided it might be well suited for psychotherapy. And this was in the 70s. When he actually had these experiences, and it took off. In the 70s, it spread in the Bay Area, into the 80s, and then people found out it was a lot of fun to do, irrespective of therapy. And then the DEA got involved, put it on Schedule 1, and then a very, very long drought until, again, first phase 3 trial initiated in 2017 and reported out this year in the New York Times. That's how exciting these kinds of results are. This is from Jenny Mitchell, the UCSF. And again, this is PTSD after the wars of the last 20 years is a major issue. Obviously, the lockdowns and all the other contemporary issues also obviously contribute to rising diagnoses of post-traumatic stress. But again, this is a remarkable result looking at the effects of MDMA-assisted therapy, just a couple doses over months. And the question that remains, this is a remarkable effect that early studies seems to suggest go for years after just a couple treatments. And how does it work? And, can we refine it? Because again, it has abuse potential, and chronic use is associated with a whole host of things that you don't want. And if you think for a minute about what it takes to pull a drug from the market, like COX inhibitors or any number of, antidepressants, or lorcaserin, which has been used for obesity and appetite suppression, there really isn't a whole lot of tolerance for, at least in the US, for drugs that have major side effects. And that's, I think, where the work that we're doing really comes in, is if we can understand how these drugs work and separate out those good effects, let's say, from the abuse potential, then we have a way forward to designing precision therapy. Now that's precision therapy. We haven't even talked about precision diagnostics, and I'm going to turn back to Laura for that in a minute. I want to just show you again, like how do we get a mechanism? We do it through mice. We get mice to perform these simple behavioral tasks where they either hang out with their buddy or they hang out with an empty cup. And we look at their sociability over time, and we find that MDMA does something very similar to what it does in humans. Again, I'm kind of skipping over a lot of detail. And once we get these kinds of models, we can really do detailed work on what are the neural elements that control these things. And one of the more exciting things that we're doing is now really looking across the entire brain for what is it that may mediate that social effect of MDMA. And then this lines up beautifully with the work that Laura is doing in the Precision Mental Health Lab, looking at MDMA in humans, where they're mapping brain-wide effects in humans on MDMA. And what's in common is that none of these things really assume a specific receptor. We're not screening receptors to understand the mechanism anymore. We're not even assuming that it's all happening in one brain area. All we're assuming is that activity, whether in a human or a mouse, is somehow related to mechanism and behavior. And so, we're in a mouse, at least, we're able to, again, without going into too much detail, we're taking advantage of some very exciting developments in neuroscience to be able to map entire brain's activity at cellular resolution, and then compare different states, like mice on MDMA versus mice on methamphetamine, social context, non-social contexts. And then we can identify and control those neural elements. And that's something you can't do in humans. And again, so we find some brain areas that really seem to be selectively involved in that social effect, and we're able to map them out. And again, I think I think we can pause here for a minute. This is really where I think, Laura, your work is going. Is, we have this signal in a mouse. What are we going to do with it when we get to a human?
Yeah, it's a great question. I think that it's gonna, one thing, just to help us understand where these drugs are acting in the brain, and potentially, as you say, use that information to kind of isolate the therapeutic effects and separate those from the abuse effects. And so, yeah, go ahead.
So I'm thinking, that one of the things that has been very hard to study, we're still, we're at the very earliest stages of understanding how MDMA, first of all, whether it's effective at all. I think that is a really important thing to say up front, is there is exactly one phase 3 trial that's appropriately powered. That this, if this were a new drug for blood pressure, I think, that's really the bar that we should be thinking of. It's worth mentioning that there's so few effective therapies for PTSD that, that's what breakthrough status I think is for, and why this is getting so much attention. But there's still this idea that, we kind of treat everybody. It's hard to differentiate, even in something as magical, I'm using that, in air quotes, as MDMA, it doesn't work for everybody. It's actually not a cure-all. And it may be just as informative to understand, are there people that it might work better for? And are there, what can brain imaging tell us about that? And how do we put that back into a mouse to understand individual differences? I think those are important questions. And how many patients have now gone through the MDMA protocol? I think we're still at number 1.
That's right. Yes.
So it's probably too early to make any broad conclusions, but I don't know. Can you tell us a little bit about what what you heard from this patient in the scanner?
Yeah, so I mean, she definitely had really a profound experience of euphoria, and she doesn't really have a history of trauma or any current psychiatric diagnoses. That's part of the requirements for our study, that they not, that they're healthy volunteers. But nevertheless, she still said that, she ended up thinking through some things that were going on in her life, and kind of felt like she came to some resolution for some of them. And I mean, of course, that seems to be what's going on as well in PTSD and other disorders that MDMA is being investigated in. Of course, with PTSD, it's, more focusing on that specific trauma and trying to reprocess it and kind of have a new relationship to it. But it doesn't have to be specific to that. That's certainly been the focus.
I'm desperate to know where, what, again, this is all happening in an MRI during functional imaging, that you've essentially caught on camera someone having an emotional resolution. Again, it is not the same as PTSD, and that's an important point to make. But what do mice have PTSD? I have no idea. I'm not that hopeful, actually. but I think the important, what are we using mice for, and why are we doing these side-by-side animal human experiments, is that what you caught on camera, someone having resolution of emotional trauma. And, we have these crude ways of measuring that even in humans, where we kind of think that relates to, your ability to relate to other people. And that's we're modeling that kind of behavior in a mouse. But what you see on imaging, that is something that now we can put directly into our own studies, where we have brain-wide activation maps of MDMA in a mouse in various contexts. And that's exactly what we're looking for. It's something that's conserved across species, and across time, that's really basic, is resilience and recovery from trauma. And that we think, that's the basic, that kind of underlies all of this work, is that these things are very much conserved across, across evolution. And if we can understand how those things happen in some detail, then maybe we can recreate them in a more targeted way. I'm really curious. Some patients are not going to have that experience. They're just going to have some euphoria without emotional resolution. So to me, that is really the value of being able to do this in the same institution and being able to work together so closely, because that's you don't want to adjust studies too much on the fly. But this is really like, it's there's a conversation going on, at least across the species divide, that I think is super important.
Absolutely. Yeah, just in talking about this particular participant, she's so great, because she just really shares with us everything that's going on, and we just have a ton of questions for her about her experience. And one thing she points out, as we know about this drug, is that it makes you want to connect with others. There's this pro-social element, and she kind of jokes, "Are you going to give us a hug, or give me a hug?" And it just kind of makes me think about the environment that we're doing the study in, which is kind of a pretty sterile environment. It's actually, we do these administrations in a conference room, and
it's not Burning Man. It's not a Burning Man.
Not Burning Man, no. And so we, it's really in stark contrast to the philosophy of the MDMA assisted psychotherapy and the manual that Michael Mithofer has written, with having, a comfortable space and a couch and, heating pads and natural elements and, soft things. And we really have none of that in there. And we don't really have the resources for it in our grants, but kind of makes me think, should we be including that as part of the experience? Because that's how it kind of makes sense to do that, and just to make people feel comfortable when they're in this altered state. Or do we want to see their brain more in this very kind of sterile environment?
I think that's there's a lot of there's some interesting things written. Harriet DeWitt and Charlie Grove wrote something about studying. They both studied MDMA and psychedelics like LSD, psilocybin, in both laboratory settings and also therapeutic settings. And there is very much, especially in our work, at the same time as we're trying to understand how these things work in disease models, right? Where, again, how does ketamine work for depression? How does psilocybin work for chronic pain? There's also this idea of like expanding human potential, where, precision mental health is actually an interesting concept because it doesn't have to apply to disease, actually. It can just apply to, how do you, if you're going to categorize people, we can talk about different types of blood pressure regulation. We can talk about different immune responses, but we really don't have a language to discuss different types of personality in a quantitative way, and how those things are going to interact with drug challenges, how that interacts with setting. And here we have what we're developing is a really powerful tool set to probe those kinds of mechanisms. So ideally, I see you're also a fan of is it grapefruit? Do you have grapefruit? I have grapefruit.
I've got raz cranberry.
Interesting. Okay.
Yeah.
Anyway, we'll probably edit that part out. It's again like the being able to, like, how do we move this forward? And what is so important about these MDMA in particular, and to I think some extent psilocybin, maybe to a lesser extent ketamine, is the set and setting part of it. How do these therapies work? If you look back at that, I'm going to share my screen again. I want to highlight something from the MDMA trial, actually. This right, this is the severity of patients, at the beginning. This is essentially non-functional patients with very pretty severe PTSD symptoms, and this is how they do with MDMA, which is great. This is how patients do with therapy. It's we're looking at this like, how do we split apart the drug from the therapy, as if with the underlying assumption always seems to be, how quickly can we get rid of that placebo effect therapy intervention? And what this is so clearly showing us is that therapy, especially intensive therapy, has a profound impact on recovery. And how do you study that? You need an appropriate setting in order to really deliver that. And that's, so again, like the kind of mechanistic studies that you're doing now with normal, with healthy controls are just as important as having side-by-side trials where we, again, look at what is happening in a therapeutic context. And again, splitting apart which parts of therapy are necessary, which parts are sufficient, how does it interact with the drug? And this is kind of the whole idea of like brain state engineering. I'm going to actually show you an example of, again, like where, how do we develop tools to even do that? Which is, I think, what I'd like to, that's really what I'm, most interested in. Edit that part out too. But here, let me get back to my slides. And again, just a couple pictures. Sorry for the seizure-inducing movement, but this gets at mechanism in humans. So, or you're doing this work with MDMA in healthy patients in the scanner. So we do actually have some information about how other drugs in this broad category of psychedelic class compounds work for actual psychiatric disorders. So we can go from testing mechanism in humans and going back to modeling drug effects with mouse behavior. And again, that's exactly the model that we've been talking about with MDMA. And in this case, it's ketamine. So, it's again, as I mentioned, it's an anesthetic first. It was an anesthetic first. And after about 30 years of use, it became evident that it also has some pretty profound antidepressant effects. And, again, as people glommed on to, this is an antidepressant. Oh, also, it's also a lot of fun. You can find clinics popping up all over the place. There's obvious abuse potential here. Some patients really just like the numbing and don't actually get any long-term benefit. Again, so there's a signal here that is giving us a rationale to understand a little bit better how does it work, and can we really focus in on the part of this that's helping with patients' mood, their resilience, and all those things that we think are important for recovery from depression. This is just from Reddit. This it's I'm laughing, but it's serious. This is you think about how many people in the U.S. have diagnosed with depression, and how if you just make ketamine available and just with and increase the exposure across the US with 50 million potential patients, I think you're going to run into issues. So it's it's not it works pretty well, but that doesn't mean it's good enough that we should stop. And so this was the kind of the impetus for a study that we did with Alan Chatsberg and Nolan Williams, where we testing or rethinking this idea of how it works. And for a little bit of background, one of the dominant ideas about ketamine is this idea that it binds to and blocks the NMDA receptor. That's a particular type of glutamate receptor. It is one of the most widespread receptors in the brain. So it's, as a mechanism, it's interesting for a lot of reasons, but it's not clear whether it's correct. And how do we know whether it's correct? Well, we can test the mechanism in humans. So how, what's one way to test it? Well, you can test other drugs that work the same way. And, maybe you would expect that if one NMDA receptor blocker works, others should. And, as you look over, this is, many, many years and unfortunately millions of dollars spent looking at other drugs working on the same mechanism, and it just has not panned out. And, John Crystal at Yale has some very interesting and compelling arguments for why that might be. But, it's also raised the possibility that maybe NMDA receptors aren't enough to really explain the antidepressant effect. So we tested, this is Alan's idea, which is this was the first, as far as I know, human behavioral pharmacology test, meaning you block an effect, a therapeutic effect of a drug with a very precise blocker to really, as like a way to surgically dissect almost the mechanism of how drugs work. And so what we used for this was a drug called naltrexone, which there's a similar drug called naloxone that is used for opioid overdose. So naltrexone is a high potency, very selective opioid receptor blocker. It has nothing to do with NMDA receptors as far as we know. And so what you see here is this trial we did where, looking at this is just patients who receive ketamine. And this is, again, the same effect that we've come to expect from other trials. And these same patients were crossed over in random orders to a condition where before they got ketamine, they got a high dose of naltrexone. So all their opioid receptors were blocked, and then they got ketamine. Now, if ketamine is just an NMDA receptor blocker, you'd expect that nothing really should happen, but that's not what we found. We found actually that it completely blocked the effect, and that was pretty surprising to me. So again, it was a surprising finding that gives us some really important insight into how ketamine might work. So what do? We take it back to the mouse. And again, using a lot of the same tools I showed you for MDMA, we've developed a map of brain areas where naltrexone actually enhances ketamine-associated activity. And there's a lot of detail here about, whether you want to look at enhancements or, decreased activity. But the point that I want to make is that this is where mouse models are really great, is you can take a fact. And again, always, I want to be kind of cautious about over-interpreting our own data. This is a small trial, 12, 14 patients. So it needs replication, but this is, again, it's a clear signal that we saw with only a few patients that suggested is a pretty strong effect. This is the kind of thing that then you can go and model that very, well-defined finding, put it into a mouse and see what you come up with. And then what we get is what's the intersection of these two things? This is where ketamine interacts with the opioid receptor system. This is a whole novel range of brain areas that might maybe we didn't think of when we're thinking about the antidepressant mechanism of ketamine. And once again, nod to the work that's going on with our National Institutes of Health sponsored work with the P50 with that Laura, you're doing with Liam Williams, the Precision Mental Health Center. This is the kind of thing we want to look for in humans. And again, like try and bridge that gap. And what we've done, we're taking it one step at a time. We found one of our hottest hotspots for interaction was a brain area, actually the central amygdala, which is involved in responses to environmentally salient stimuli, involved in fear responses. So, there's some, there's a story that we can see unfolding here where we're looking at the intersection of ketamine with deeply conserved across species opioid system. This is something that, humans have opioid receptors, fish have opioid receptors. And, it is involved in, again, like stress responses, pain and things like that. So this is where we're focused, and we can do a lot of work in mice that we simply couldn't do in humans. And again, this is ideally then we go forward to test this in humans. And I think this is another point where we can pause for a minute. And again, I love, to me, what drives this work is the stories that we hear from patients. That's ultimately what we're moving towards, is trying to understand what is the patient experience, both in health and in disease. And I think you're actually quite a few patients in with the ketamine study and the scanner.
Yeah, we are. So we have 13 patients so far with ketamine, and then one with MDMA.
So I spent a little bit of time with some of the folks on ketamine, and that's one thing that's a little different than MDMA is it's not, the context doesn't seem to be quite as relevant. In that, patients are dissociating whether or not they're in the scanner, or whether they're sitting in an office chair, whether they're, in blindfolds, or for that matter, whether they're in an operating room. So that's that is actually a good segue to the last big project. And Laura, you've made a really important contribution to this stuff. I'll share some more slides. Again, like this mechanistic work has implications for patient care, and also the work that we do with patient care can actually give us an idea about mechanism, important points about mechanism too, and I'll touch on that in a minute. And again, I'm just harking back to this email I got from this patient is, I'm actually an anesthesiologist. I go to the OR, a day or more a week, and we sedate patients heavily, put them into, deeply anesthetized states. And then they come out and, it's like the lights off, lights on. But what happens in the middle is a little bit of a mystery. And, one of the things that we think about a lot in these patients are risk factors, right? Putting somebody to sleep and performing major surgery on them is not a normal thing that, one would do until, the advent of antiseptics and sterile surgical technique. So, what we focus on, these are intense stressors. That's really what I'm trying to say. It's pretty rare that you know the date and time of the next huge stress you're going to undergo. And we know, that stress has effects on your heart, your lungs, all of your major organ systems. And we've done a great job in perioperative medicine looking at all these cardiopulmonary factors. Now, I think, Laura, you could probably attest to the fact that, we know that stress is actually probably the single most important precipitant of psychiatric disease, to which, as Rob Malenka might say, duh, right? That's not a surprise. What is a surprise is how little, we just can't do anything about it in the perioperative space. What, if you find out you need surgery in a week, what are we going to do to prepare you for that? And, on the list of things we worry about, it really is more in column A and much less in column B, for the simple reason that we don't have rapid acting therapies that work this fast. So now, ketamine obviously is one of the first exceptions to this. So, and again, like, how big of a problem is this? And, we've, over the last couple of years, we actually developed a screening program just specifically to look at this. And this is funded entirely by the Department of Anesthesia. This is the kind of thing that does not, it's not easy to get NIH interest in this. Again, like, depression is, widely prevalent in society, but we're looking at a population that I think you'll agree is acutely at risk. And I'll show you a couple, I think, kind of harrowing statistics. But so again, like, this is patients gathered over the last year. We targeted patients with a history of depression. Out of 12,500 patients that came through our clinic, we identified 2,000 of those with depression. We surveyed among those about 1,600. We got a pretty great response rate. And we just asked them these two questions. Again, we're not psychiatrists, but we work with psychiatrists. And the least we can do is this very simple primary care level intervention. It's called the Patient Health Questionnaire 2, PHQ-2. If you can answer these two questions, if you score a 3 or above, that has a lot of predictive validity for you have symptomatic depression. And so what we find is that we found, out of 1,000 patients, again, there's some filtering criteria here, 17% have symptomatic depression. That's quite a bit. And some of these are, we say moderate or severe. Think about it like heart disease for a minute. Moderate to severe heart disease means you cannot get out of bed without getting winded. Think about that as in psychiatric terms, a severe depression. That is what we are talking about. This is not, I feel pretty bad today, but I'm still at work and I'm doing an interview with Laura and Jacob. That's not, that might be mild, but that's not incapacitating. What we're talking about is incapacitating mood disorders that, again, patients are able to kind of get by, and they somehow present for surgery, and we somehow had no idea about it. And the question is like, well, actually, we didn't get to that question yet, but the question that we're trying to answer through this screening program is, once we identify these patients, a number of these really are high-risk patients who've never been diagnosed, who don't have any psychiatric care and are not on any psychiatric drugs, some of whom are expressing suicidal ideation, which is, again, like, these are preventable, screenable issues that, you add a big surgical stress on top of this. And I think it's pretty easy to predict bad things happening when, simple interventions like patient education, outreach, before we even get to ketamine and, magical new therapies, those kinds of things, that's really what this is targeted at. And this is not work that's easy to fund, because right now we're, essentially doing it as a free clinical service. And Laura, I just want to take another opportunity to thank you very publicly for donating your time to helping us screen some of these folks and understand how to treat them. And I'm going to wrap up with just a couple of the studies that are ongoing. So now that we've identified these patients, as I kind of alluded to, one thing we can do is try and treat them intraoperatively. And that's, if you think about it in broad terms, we're actually doing something very interesting and testing something pretty novel. If you think of ketamine as part of this broad class of rapid acting therapies, like psilocybin and MDMA, one of the unifying themes is that, especially with MDMA, is that you prepare patients, you set intentions, expectations, and then you have the drug session. And then after the drug session, where again, we don't have a clear understanding of what happens. After that, you integrate. In other words, you take the aftermath of that powerful experience and you try and apply it to your life. Now, this actually fits with like the surgical model as well. I mean, there's preparation, there's the intense intervention, and there's integration. And we're now incorporating ketamine into this. And what's more is we're doing it in such a way that the patient doesn't actually know that they're getting an intervention. We're giving ketamine during surgical anesthesia. So, we're addressing one of the biggest issues, I think, in psychedelic medicine, which is if you know you got the drug and you're supposed to get better, there's no way to prevent you knowing because the effects of the drug are so obvious. How are you ever going to do an actual comparison to say that it was the drug and not all of the associated hype and excitement and expectation baked into it? So we're actually able to do it, and that's because ketamine is FDA approved for anesthesia. So this really is a pragmatic, unfunded, except for the Society for Neuroscience in Anesthesia Critical Care, who actually gave seed funding for this, which I think was very forward thinking. But so anyway, we have an opportunity to answer a really, I think, interesting mechanistic question is, how much does the role of conscious perception play in these rapid acting therapeutics? And we can ask the same types of questions about psilocybin. I think, based on Laura, the report that you gave on the patient on MDMA, I think probably you need to be awake for that. That really, again, the mechanisms are different. It's important. It's important to recognize the differences, but again, we have to suss these things out. So that's the trial that we're doing right now. Does ketamine even work if you're not, if you're not there to know that you got it? And I'm very grateful to be working with psychiatrists on this, like Laura, like Alan Chasberg, who we're designing a psychiatric trial in the operating room. As far as I know, there are very few examples of anything like this, where we're looking at the same types of patients you might enroll in a trial. We're looking at the same kinds of outcomes. And again, we're 80% of the way there. So we'll see. And I'm just going to skip over that part. The last thing I want to, again, really point out about the intersection of psychiatry and anesthesia is something really, this blows my mind. This is something that a colleague of mine, Harrison Chow, if I could give him more than 100% of credit, I would, because this really has been his idea that he can induce dreaming with certain anesthetic cocktails. And what's more, that when you induce dreams in some patients, especially ones who have post-traumatic stress, you can get dreams that actually result in the resolution of emotional trauma. And this is, again, and I want to thank the patient I'm about to describe for letting us talk about this. This is a woman that came to our operating room about a month ago, and she had suffered a knife attack from a family member. As you can imagine, that would be extremely distressing. And in fact, she had not been able to sleep for 6 days, short of resting in bed. Basically terror and extreme anxiety about, just reliving the attack. Now, Harrison saw her in pre-op area and talked to her and thought, this is a great potential, this is what he's been doing. He's been kind of trying to induce dreams during surgical anesthesia. So the orthopedic surgeon took her back to the OR for definitive repair of tendons. And Harrison did his thing, and during the sedation, so she had a long bout of sedation, and this is her EEG. And without getting too deep in the details, one of these things is not like the other. This is basically a readout of the frequencies that her brain is generating during anesthesia. And you can see something happening right around here. And we have a pretty good idea that this is probably where dreaming happens, because again, this is something that we're working to develop is, how do you monitor these brain states during anesthesia? The most remarkable thing about this was she woke up and was crying with joy. She reported this dream during anesthesia where she relived the knife attack. She relived going to the operating room. And in her dream, she completed surgery, got home, and had full functional recovery of her hands. And we had the honor and privilege of following up with her. She was so excited to tell us about this. So Laura, you talked to her, I talked to her. Harrison, we had a neurologist, Makoto, who also spoke with her about the content of her dreams. And she is completely resolved, no symptoms. This is N of 1. So again, this is a very exciting area. And Laura, I know you talked with her in some detail, and what did you make of this case?
Yeah, just as you mentioned, just really incredible. I mean, I certainly, in my experience, treating people with depression and PTSD, have never heard of such a case before. She really did have some pretty severe symptoms after this life-threatening, obviously very scary situation where the family member came out at her with a knife. And it's just so interesting because the dream was basically the same thing, just kind of a section of that attack, just swinging like the knife over and over again. But interestingly, then looking down at her hands and not having any wounds. So it's, seems to be some form of reprocessing the trauma, but under anesthesia. And she really has pretty much, very, very mild symptoms related to the trauma at this point.
So, this, again, this is getting to what's so exciting about this. I mean, there are a number of things that are exciting. One is, it's not uncommon for us to take care of patients with acute trauma. And the last thing that we're, focused on typically is trying to get them to actually work through the trauma during anesthesia. We usually worry about, trying to keep them, their heart, lungs, circulation, temperature, all those kinds of things. This is an important thing. This is an opportunity. We have a patient in a very different state of consciousness than they would ordinarily be in that may be particularly malleable, and we can work with that. Or more actually, maybe a better way of saying it is let the patient work through it on their own. One of the most interesting analogs to psychedelic therapy, I think, is this idea that, the way that people take MDMA and psilocybin at Burning Man, for example, is quite different from how it's taken in therapeutic settings, right? So it's not a party. Actually, with psilocybin, you have eye shades, you have headphones, and this idea of basically silencing external sensory input. We can take that analogy a little bit further and, to say that, what if we silenced internal sensory input? The idea of your ego, your sense of self actually may be what's holding you back from releasing trauma. These are very poorly defined concepts physiologically and anatomically. The fact that we know when and where that might happen, and we can visualize the process with EEG, with MRI, that is remarkable. That is again, what we're developing tools that allow us to get at the mechanism of really fundamental processes for healing, and also just for general, human expansion of human potential. So, in some ways, this echoes a long-standing argument among psychotherapists that practice ketamine-assisted psychotherapy, where some people think it's very important that you work in that state that ketamine puts you into. We have some evidence from our trial that it even works when you're unconscious. And we have this dreaming thing where maybe what is actually happening is you're you're really letting a process, a self-correcting process go forward. You're taking the brakes off. Why are we so arrogant to believe that, our egos need to be there to observe the process of us healing? Maybe that's what ego dissolution and ego death is, during these intense psychedelic experiences. Anyway, these are obviously just abject speculations, but again, I want to really point to these as doing these, achieving these kinds of outcomes in very structured settings with, again, control of physiology and through powerful pharmacological manipulations. That's how I think we're going to get there and be able to start, uncovering the mechanisms of some of these really deeply human processes. I think that's that really takes us to the next steps of how do we keep this momentum going, because as of right now, the NIH is still, I would say, interested, but not so enthusiastic about stuff like this. This is really, I would say, on the outer outer edges of where mental health treatment is going, and certainly, I think it's the cutting edge of where neuroscience is. What do you think, Laura? What's the future hold for this kind of work?
Yeah, I mean, obviously just incredibly exciting. But as you point out, there are things that, we need to be cautious about, certainly the abuse potential. And it, raises the issue of, that these therapies are not going to be for everyone, and trying to think about how can we figure out who is going to benefit from them the most. And so, that's certainly something we are thinking a lot about in the center, trying to identify baseline neuroimaging signatures that might be most predictive of response. And so that's, we can offer these therapies to those individuals in particular. And then, I think another really key issue, and, you're doing really innovative and important work on it, is just how much psychotherapy during the session do we need, if any, and, do we need to be conscious or not? And it's really an important implementation and access issue, because, in the MDA protocol, it's the 3 dosing sessions are very long. They're 8 hours. Right now, the protocol is that two licensed therapists are needed throughout this whole session. And, it just, cases like this where people are getting better under anesthesia, or, I've had examples of people I've treated with ketamine, where people have said that they've just kind of, worked through an issue themselves and kind of processed the trauma without any guidance. Kind of raises the issue of, do we necessarily need the licensed therapist during these sessions? Maybe some people do need them, but maybe some people, are starting out with kind of the ability to go inward more and reprocess the trauma themselves. And so maybe we just need more medical monitoring and kind of someone there if people, start having a bad experience. But maybe then talking about, I think, the integration is going to be important afterward. But I'm very, very curious and interested in this idea of just how much support do we need during those dosing sessions? Because if we do need 2 licensed therapists to be there for 8 hours during 3 sessions, that's going to be a huge issue in terms of rolling it out to so many people with PTSD that really need this therapy.
That touches the access issue, I think, is very important. And that, again, if we just stop here with what we know or what we think we know about how MDMA, for example, works, price tag is about $15,000 a patient. Plus, you have this issue of where do you find, you need therapists. That's really the main shortage. And, there's a reason why there's 2 therapists. It's actually, the idea that you're putting someone in a very suggestible, vulnerable state. You want to, the therapist is an important part of the equation, both, therapeutically and also to prevent harm. And that harm can actually even come from patient-therapist interactions. There are all kinds of things that, this is why I did an anesthesia residency. It's because this is not, this is not my domain, but, the idea of like transference and countertransference, like those concepts I remember from medical school, but they're powerful. Things that happen in therapy, and MDMA, any kind of like powerful conscious altering drug, can just amplify that. And those are actually, I think, real patient safety issues. And so again, like all of these questions around patient access, safety, really start depending on how exactly does this work. Can we identify who can do without it? But how do we? And again, I think it's important to emphasize that this is never about, in my mind, about denying the role of psychotherapeutic support. In fact, I think that should be enshrined in capital letters whenever we talk about MDMA or psilocybin, even ketamine. That I don't think that the model where you just give ketamine in a vacuum, or I think God forbid send people home with large doses of ketamine for unsupervised administration. I don't think that's happening, but we don't know. That's not going to be a successful approach as like a public health standpoint. But again, having therapeutic support before, therapeutic support after, and then catalyzing these transformations in a safe way that can be, again, rolled out in any number of ways. Group therapy before and after. Like there's so many models that haven't really been explored or have only just started to be explored. I think that's where we can't get from point A to point B, I think, without a lot more work in this area. And again, like it requires rigorous science. And honestly, like the next this is just the first iteration of psychedelic medicine. What we learn from these current, honestly, crude therapies, crude and powerful, I think we're going to be able to spin into something more precise, more directed. Yeah, I love the idea of, brain stress tests, emotional stress tests that you can, combining imaging and, and behavior, and really to understand a little bit more about a person in a pretty short time. So that's where I hope this goes over the next few years, as our group grows and our collaborations deepen. So yeah, we'll see where we end up, but it's a pretty exciting road right now.
What do you think we need to, what kind of resources do we need to implement these studies that are going to be so important?
So first, I'll tell you what I don't think we need, which is we have enormous intellectual capital here. I thought I was going to do residency in New York at Columbia or something. And I came to Stanford and I realized the number of just the kinds of conversations I had just in one day across, human neuroscience, animal neuroscience, like the potential for really transformative work in medicine. That is what drew me here and why I've stayed. So we have a fantastic extended network of collaborators with deep experience in these areas. And we've already spent years working on drugs like MDMA and ketamine. So it's to go to the next step. I think we touched on this early on. We have a lot of our strength is in understanding mechanism and in translating across this divide, of species. And what, in order to really interface with the broader community, that's really interested in psychedelic therapy, I think we really need to hone our ability to on the therapeutic side, developing, a therapeutic program where, again, we have trained therapists where we really, if we want to understand the role of therapy, we need to be able to deliver high quality precision therapy. And again, like it's all part of this, a new set of tools that we have for really precision brain state engineering, I guess is one way. That's a very Stanford way to talk about it. But again, it's a combination of psychotherapy, targeted, pharmacological manipulations of consciousness, hypnosis, brain stimulation. These things all are going to work together to achieve precise outcomes. But it really, what we need is, I think, the therapeutic side of it. And again, having clinicians and training programs that are really devoted to that aspect of it, which is, again, also, there's a lot of room to grow in how these therapies are delivered just on the practical side. What types of therapy you do, et cetera. I don't know. What do you think, Laura? What do you think we need?
Yeah.
You have the fireplace, so you just need, if you put some stockings up for your Christmas wish list for Stanford psychedelic research.
Exactly. Well, I think, if, right now we're doing these more mechanistic studies and humans with people without psychiatric illness, so healthy controls. But if we're, going to start, if the center certainly has plans to start doing studies in people with, depression and PTSD with ketamine and MDMA, I think it just will be really important to have, the adequate space and to, as we were kind of saying before, to make our patients feel comfortable during these sessions.
I think that's really the dream, is being able to combine all of these technological advances and very sophisticated approaches with really putting that in a much more human context. That is an enormous challenge for research. If you just think about even down to animal work is, we know how much environment plays a role in these things, and it's just that's the kind of thing that takes resources and time to develop. So I think we are on our way, but there's a lot of room to grow.
Yes, agreed.
Jacob, after listening to all this back and forth, what do you make of it?
I think that all of this is incredibly exciting to kind of be part of, especially from the perspective of actually watching the participants come in and getting to see reactions to the different doses when we're doing ketamine and MDMA clinical trials. So I think that the future is bright when it comes to precision mental health and precision psychiatry as a whole. And I think that as we kind of progress in better understanding the mechanisms like we're doing in these clinical trials that we're all involved in, I think it's going to become abundantly more and more clear as you and Laura were talking about which circuits we're really talking about in the brain, and ultimately who are the individuals that are in need of these types of interventions. And I think that having such a talented cohort at Stanford, which has enabled research that spans from animal models all the way to human-based mechanisms and application, is just really exciting to be a part of. And also contributing to what will hopefully in the next 10 years become really the future of psychiatry.
Cool. Well, thank you again for inviting me on to chat. We're all going to see each other outside of this very, very soon as we continue with the human experiments with ketamine and with MDMA, and we'll continue to have a lot more to talk about. And look forward to working with you guys.
Absolutely. Yeah, definitely look forward to our continued work together.
Yes, thank you for joining us, Boris.